can be joining. Oh, thank you for that, Amelia. I almost forgot about that. So let me share my screen. Can you see it now? So this is the, let's go to the center mode. Oh, doesn't want to work. There you go. All right, so welcome everyone. This is our first Global Health Network AYA webinar of this season. The goal that we have with this set of webinars was to first set the stage and have like 5 professionals from each of the 5 WHO regions to share with us what's the current situation of AYA care, cancer care, at each of their continents or their regions. And then we will have like a special webinar for each of them. So we acknowledge that the information, the amount and the precision of the information in this session is not going to be inclusive. So none of us will be able to share all the details of what's happening in your region of the world. But the idea of this is to be like the first step to start a conversation about and to learn what is happening elsewhere and how we can get to work together. So for today, we have 5 very impressive speakers, not me, but the first 4 of them, who have very extensive curriculums, and I'm not going to go through all of that, so we don't spend time with that, but I share that with our community in the invitation link that I sent. So representing Asia will be Dr. Ruzanna Papyan, she's from Armenia. Representing Europe will be Dr. Apostolos Pourtsidis. I'm sorry if I said the last name wrong. Representing Oceania will be Dr. Ursula Sansom-Daly. And representing Africa is Dr. Gita Naidu. And I will be representing Latin America. I'm Villanueva. I'm from Argentina. So without wasting any more time, I will ask Ursula if you can share your slides. Each speaker will have like 10 minutes to share that's like the current situation. And then at the end, we're going to go through some questions.
Sorry, just looking for my slides here. Maybe if I just, there we are, cool. So everyone, thank you so much for inviting me, Gabriela, and it's a real pleasure to have, or to be with you all across the world. And I suppose what I would say at the outset is I feel conscious, speaking about Oceania, as Gabriela said, that I can't do the region really justice in the short time. So what I will show you today is a bit of an overview of our region, essentially. And I want to thank a number of wonderful colleagues who have assisted me to pull together some of these overview points for you, including Professor Claire Wakefield, who you might know as being the president of SIOP Oceania as well. So when we think about Oceania, really, we are kind of like an island continent, so consisting of 14 countries, 10,000 islands and 44 million people across all of that, spanning a space of, over 8.5 million kilometers. And really in our region, you can see really, I'd say the kind of the most high income to also extremely low income parts of the world. I'm based in Sydney in Australia, where, as I'll share in a moment, we are very fortunate to have very, very high quality healthcare systems, but there are other parts of our region where that's really not the case and where outcomes are really, really different. So this is a bit of an overview of some of the countries in our region. Now, what you can see on the screen here is actually pediatric data, so it's child data. And one of the things that I would say is that the concept of AYA, or adolescent and young adult, as a subspecialty is really something that is a lot more advanced in places like Australia and New Zealand than it is in our neighbouring countries in the Pacific, like Papua New Guinea or Fiji. In those countries, even pediatric or child cancer treatment is really still very much developing and emerging. So that's the context I would put around that, is that actually even the concept of having AYA as a subspecialty or a focus is not really universal. But you can see, looking just at the pediatric data, in Australia, we have, just under 1,000 children a year. In New Zealand, it's a much smaller number, 150 children a year across only 2 centres. And you can see how that differs. Very, very small numbers in a lot of other Pacific countries. But then what I would also say is that probably a lot of those cases are not even being diagnosed or detected in those healthcare systems. And then there are a lot of island nations where we don't even really have data. So there's a lot of work to do in the region. I wanted to share, I guess, a couple of the kind of unique elements of cancer in our region. And I suppose today I'll have a particular focus on Australia and to an extent also New Zealand, because Australia is where I'm based. So for context, I'm a clinical psychologist working in a youth cancer service, an AYA specific cancer service in Sydney. So what you can see here is the map of Australia overlaid onto the map of the US, just to give you a sense of the size. So we are a very big country, but different to the US, we have a very, very low population density, and it's one of the absolute lowest population densities in the world, really. So you can see in the UK, they have a population density of something around 275 people per square kilometre. In the US, it's 35 per kilometre squared. In Canada, it's 4, and then in Australia, it's 3 people per kilometre squared. And really, part of that is that we are very much concentrated around the coastal edges of the country, and in particular down the southeastern part of the country. So Sydney's here, Melbourne's here, and that's kind of where about 97% of the country lives in this corner. 97% of the population lives in this corner of the country. So there's huge parts of the country in the middle that are very, very, very sparsely populated. So that has an impact on how healthcare is delivered as well. I'd say one of the biggest things to flag about AYA care in Australia is that over the past decade, or a bit more than a decade, we've had the youth cancer services being developed. And this has been as a result of a lot of advocacy, but also a lot of funding, including federal government funding that has been invested and sort of been kind of administered and kind of coordinated through Canteen, which many people would be familiar with. But Canteen's a charity or a kind of philanthropic organisation really for young people living with cancer. But so the Youth Cancer Services is a network of healthcare services that are designed to provide specialist interdisciplinary cancer care to young people aged 15 to 25, which is how we define AYA in Australia. And so with the Youth Cancer Services, we have 5 lead sites, and you can see Sydney's over here, and that's where I'm based with my role clinically. And we have 5 lead sites across the country. And then those sites are all in cities, as you can kind of hear, and then they are kind of networked in with a number of other hospitals across the country. But the kind of lead sites where there are kind of staff supported or paid for, funded through the Youth Cancer Services, they really exist in the cities, but kind of networked in with those other hospitals. So that's kind of what that looks like. And so, yeah, those 5 lead sites work with 25 or more other hospitals and health services across Australia. And you can see it's quite a wide, expansive country to be working across. And I think that having that Youth Cancer Services network has really vastly improved cancer care for AYAs in Australia. And the Youth Cancer Services have sort of evaluated themselves, and it looks like about 75% of newly diagnosed AYAs currently are being treated or supported through the Youth Cancer Services, which is fantastic. Obviously still work to do, but I think that's really excellent to be sort of seeing and supporting that many. And this is one of the papers where they have kind of done some evaluation to look at metrics around those cancer services. And so I think, it's kind of may be useful to look at, for elsewhere, if there are people developing services or looking at how you can be able to kind of evaluate how you're going with that. That could be a useful piece of work to reference as well, in terms of how you track the reach and the scope and the activity of those services. So really the youth cancer services do provide specialist multidisciplinary care for young people. Like I said, I'm a clinical psychologist, and in my youth cancer service, we have a lead medical oncologist, senior clinical nurse consultants, we have social work. So we have a range of disciplines. I think funding is always a challenge, and I think we could always do with more funding for the young people that we have, but I think that's a situation shared across our healthcare system. So, and I'm sure shared by others as well. But yeah, I think we do have quite a privileged position in Australia with the youth cancer services having been set up. And so, yeah, this is data from 2021, 2022. So 1,907 cancer patients were supported by us over that time. So you can see in Australia, our numbers are relatively small compared to bigger nations in the world. So we do have really excellent survival statistics though. So these data come from national statistical reports in Australia, and you can see they've been kind of improved over the reporting period, but really pretty stable and high over that time. And now looking at about average of 90% survival across 15 to 24-year-olds. And I guess one thing to note there is obviously that average hides a lot of variation. So for example, melanoma is one of our most prevalent cancers in Australia, and that has really quite excellent survival. But as an average, it's really fantastic. One of the things to note, of course, is that we have, what's called socialised healthcare system, or, where the government kind of funds really our healthcare. And so pretty much everything that happens in hospital should be largely free for patients in Australia. There could sometimes be gaps for some things, but, healthcare is largely free. So that I think could have something to do with potentially the great outcomes in Australia as well. Though, of course, even in Australia, we have increasing attention being paid to the financial toxicity of cancer. So it's still an issue, all those out-of-pocket costs. I wanted to flag a couple of the issues in Australia. So one is that we do have relatively poorer survival among our Indigenous young people. I will say the data, you can see the very wide error bars here, and that's because the estimates are much less certain. And probably, if anything, it's an undercount of incidence in terms of how many young people of an Indigenous heritage have cancer, because, many may not disclose or kind of self-identify in the healthcare system as being of Aboriginal or Torres Strait Islanders descent. But nevertheless, that pattern seems to be there. The other pattern that's worth noting is that survival seems to be slightly worse for young people who are living further away from our metropolitan cities. So you can see remote and very remote regions doing poorer there as well. In New Zealand, you can see this is a map of New Zealand, and you can see their cases are far fewer. So they have, from the most recent data, they had sort of about 190 young people per year diagnosed with cancer, and you can see how they're sort of spread across the country. And again, you can see it's quite a kind of a sparsely or a spread out kind of network of AYA cancer services, and the ones in bold where they have particular key workers, or kind of which might be called a care coordinator in other countries who look after AYAs. And their survival is also pretty high, 84%, but you can see there's a slight gap, so just 5% lower survival than Australia. And one of the nuances there also to flag, which is not dissimilar to our Indigenous data, is that they have a higher incidence among their Maori and Pacifica Islander people. And you can see that there is a survival gap there among those Indigenous New Zealand AYAs. The survival gap is narrowing over the data period that they've been tracking, so that's really positive, but it's still there nevertheless. And the other pattern that I mentioned before with the rurality also seems to bear out in New Zealand as well. So this is from that recent report, and they've shown slightly higher survival, 85% compared to 81% if you're in an urban area compared to rural areas as well. So these are a couple of great policy documents that I can recommend to you in our region. So this is the AYA Vision 2033, which is a piece of work that's really been led by Canteen in Australia. And this is the action plan in New Zealand. And both of those documents really set out a vision in each of those countries to reduce the inequities and to kind of expand access to kind of gold standard best practice cancer care for adolescents and young adults across the country, sort of no matter where they come from. And I think it's important to kind of highlight that in Australia, AYAs have actually been featured in our national cancer plan as a priority group as well. So even at the national level, that's a really positive thing that they're being seen as a priority group as well. I just wanted to quickly finish on a couple of challenges, speaking again to that broader Pacific context. And this is with, very great thanks to Claire Wakefield, who's leading this work. And again, this, it's hard to know to what extent this applies to AYA versus the pediatric space in Pacific, in our Pacific neighbours settings. But, in those settings, there are a number of clinical challenges that they face, like, perhaps not even getting diagnosed or being extremely late to presentation, even access to medicines, pathology, access to radiotherapy and surgery, really serious comorbidities, which I think speaks to the broader kind of health and healthcare system of the populace, and treatment non-completion, because, if treatment takes people away from their communities, or if it's not feasible with needing to work and how their communities need to be able to be supported, then it's not feasible for them to complete. The other thing is that there are issues from the setting of kind of health professionals, and there's a lack of kind of professional education in kind of the optimal cancer care, and I suppose a real lack of critical mass of patients, and also a lack of data. So very, very recently, Claire Wakefield's been part of leading some work where they've kind of established the very first cancer registry in Papua New Guinea for children. And so they just didn't have a cancer registry before. So, starting with some really important basics. There are complexities with traditional healers and those kinds of approaches to health. And of course, the kind of broader issues around complex political environments and natural disasters, which can throw anyone's healthcare system into huge chaos. I won't spend too much on this except to flag that there is some wonderful work being led by Claire and colleagues in the CEOP Oceania space, in the pediatric space. And so hopefully, I'm optimistic that might hopefully grow to extend to to AYA as well, even though it's not really a subspecialty in the region yet, but there's scope. I won't spend time on research because I know we're short on time, but just to flag, if anyone's interested in AYA research in Australia, please feel free to contact me. I have the honour of leading the Behavioural Sciences Unit in Sydney, which is a large research group. We have a focus on children and AYAs, and there've been some fantastic initiatives that have been able to take place in Australia. So this piece of work was led by Pandora Patterson and colleagues, which is the AYA distress thermometer tool, which they developed, which is really a very important clinical tool to be able to use to regularly screen for distress and psychosocial needs of AYAs in clinical practice. And we've been able to lead research as well, looking at kind of palliative care. And this is a piece of work that I've had the pleasure of being able to lead, which is advanced care plan and communication documents for AYAs in Australia, for whom their cancer may or may not be curable. So I'm going to finish up there. Sorry, I've gone slightly over time, but I really want to flag these wonderful colleagues that you can see on the screen, who are also really excellent contacts for AYA cancer in our region. And my contacts are on the screen there as well. So I'm really happy for anyone to reach out if it could be helpful to discuss any of this more, or to kind of connect about AYA cancer care in Oceania. Thank you.
Thank you so much, Ursula. This is Wonderful, very inspiring. I don't know if there are any questions right now. I guess we said we're going to do the questions at the end. So if it's okay with you, if there's any questions that come for you, I will send it your way, to your email. Right.
That'd be so great. Yeah, thank you so much for having me. And I apologize, I'm going to duck off a bit early, but yeah, really happy for anyone to be able to contact me and reach out, and happy for slides to be shared and things. That'll be fantastic.
All right, thank you so much. So now, Apostolos, Pourtsidis, if you would like to share your slides and enlighten us with what's going on in Europe.
Yes, good evening from Athens, Greece. I don't know if it's okay now, my screen.
We don't see it in presenting mode. You have to click the little cup that is at the bottom of your screen.
It's okay?
No.
Okay, just a moment.
Sure. There, now it's working.
Okay. I don't know if goes on the slides.
Yep, we can see it perfectly.
Okay. Thank you for this invitation. And for the first, the age definition, some years ago, there was a debate about the definition of ages in adolescent and young adults. I think that 15 to 24 for many years in Europe, in all countries, but the last 3 years, all the new SIOP Europe protocols register patients until 39 years old. So the new age definition is 15 to 39 years old. The SIOP Europe strategic plan, which was established in 2016, it has many objectives, scientific and medical, but for the AYAs, people, teenagers and young adults, was one of these objectives in order to address the specific needs in cooperation with adult oncologists. The strategy was to develop a comprehensive multidisciplinary program and create a European network on teenagers and young adult cancers, and at the national level in all countries of Europe, help the creation of cancer services for adolescents and young adults. So the eye care in Europe has the same problems as all over the world. Low participation of AYAs in clinical trials, and inferior improvement outcomes compared with children and elders. The problem is who treats young people with cancer and who is trained to provide care for these adolescents. Because their position between adults and children's services in healthcare systems does not allow for the best possible care and resource in this age group. But major clinical advance was recognition that pediatric regimens improve the outcome of these young people. So, where or what type of hospital treat AYAS patients? There is no meaning to discuss about public versus private. We are searching where they have to go to treat their problem, because there was some years ago a debate between pediatricians and medical oncologists, and they believe that teenagers and young adults have improved outcomes if they have their own units. This is a British mainly position, because many adult types of cancers are better treated on an adult treatment regimen or under the supervision of a medical oncologist. But I think that the most important thing is the collaboration between physicians and staffs across medical and pediatric oncology for these adolescent and young people. The AAOA initiatives in Europe, the first one is the COP committee. It was launched in 2019. We had in September Congress about caring for adolescent and young adult people, many publications with press releases. The role is to drive the AYA agenda in Europe, build international links and collaborations, AYA sessions in many cancer congresses, and plus AYA specific congresses, or also with many other groups to drive this forward. The other initiative is the ESMO COP AYA working group, is a collaboration between medical oncologists and pediatric oncologists with many activities the last years. This is a great friendly collaboration, not a fight. Also, the role is began under ENCA in 2015, the ESMO COP AYA working group. The role is to promote education and raise awareness in cancers, topics specific to adolescent and young adults, and to contact with other ESMO groups, including also and policymakers. And the last one is the ENTIAC, is a project that has been initiated in order to build the European network. Among the goals is a survey which is now under development, and the aims was to bring together all the adult oncologists, the pediatric oncologists, the hematologists, nursing, social workers, wider clinical community, and patient organization across Europe. So the forum, ENTIAC, is to facilitate wider interactions with all stakeholders across Europe. It's a great initiative. Everything is around ENTIAC in Europe. The future plans of SIOP Europe is to review and refresh the COP AYA group, is to re-energize the AYA group for novel projects. Now this year, the last 2 years, we have another project by the European Union funded, is the Strong AYA, which the aim is to develop a core outcome set and the minimal standard of cares for adolescent and young adults with cancer. There are many work groups with different projects. Also, we have the Youth Cancer Survivors European Network, which is also funded by the European community in the implementation in the Beat Cancer European Community Project. The key messages are that AYA are different. A focus on AYA with cancer is beginning to bring progress, improving clinical trial accrual, improving outcomes. And there are other many ways forward, such as the global perspective on adolescent and young adults. And please join us. In Greece, we have some problems with the adolescent and young people because they cannot hospitalize in the centers of Greece, which are now 7, because by the rule in Europe in general, also in Greece, the year for hospitalization with a cancer, a child or adolescent, is until 16 years old, and some centers, some exceptions, 18 years old. This is the oncology campus, Elpida, in Athens, the new one. So the age definition in Greece, we can care only patients until 18 years old, also in private or in a national health system. I don't know exactly where the others, young people, are treated now. I think some in adult oncologists with knowledgeable in young adult oncology. Doesn't matter if it's in a public or private hospital. And this is the FLOGA, is FLAME, is the parents' organization for children with cancer, but now they help founding the home care of facilities and for the adolescents also. And the most important thing that they are founding also many protocols in Greece. So thank you very much.
Thank you so much, Dr. Pourtsidis. This was amazing. Thank you. And then we'll move forward. I would like to ask Dr. Nita Kintu. If she's, yeah, she's right there. If you would like to share your slide, please. We cannot hear you. You're muted.
Okay, I'm going to share my slides now. Can you see it?
Yes, we can. It's not
okay. I'm Gita Naidu, and I'm from Johannesburg in South Africa.
It's not in presentation mode, so if you can just click the little. If you go to the bottom of your screen, there is like a next to the zoom thing, like you can zoom in and out. On the right lower corner, there's a little cup there that you can click, and you can put it in presentation. Or there, that's another option.
Mm-hmm. Is that better?
Yes. Yes.
Okay.
Perfect.
So thank you very much for inviting me. And I'm from Johannesburg in South Africa. And I just wanted to say, yes, it's quite interesting that to go after Australia and Europe, where so many systems are in place for childhood cancer and also adolescent and young adult cancers. And as many of you may know, especially this paper from the Global Burden of Disease, that in sub-Saharan Africa, where I come from, we don't really have much development in terms of childhood cancer and with adolescent cancer. So I just wanted to just focus on this last sentence that says the greatest concentration of Dailies are in parts of Asia, sub-Saharan Africa and North America. So for me, it's really good that I go after Australia and Europe, because it just shows how much more we have to do and how much more we can achieve. So just to show again, just to highlight that really for adolescent and young adult cancers, and if we look at the SDI rankings, and most of Africa then would be in the middle and low middle and in the low. So really it is a huge burden for us where we live. But there are so many competing interests that we have that actually there isn't even much information of how our adolescents and young adults are performing, are we diagnosing their cancers. So it is, I think this webinar is really important to highlight the deficiencies that exist actually across most parts of the world that may not include Europe, North America, Australia, and maybe Japan. So I think when we're looking at AYA cancers in Africa, the biggest problem, not only for the AYAs, but also for childhood cancer, is the competing interests of communicable diseases. And the main disease burden that we have is actually HIV and TB. So we have our healthcare systems, our governments not really emphasizing cancer, be it childhood cancer or AYA cancers. And this results, unfortunately, in many underdiagnoses and many missed diagnoses. And this is really sad, because a lot of these cancers may be able to be cured. So, and the other problems that we have where I live is the lack of proper diagnostics, therapeutics, and access to care. Also to include supportive care, nursing care, health workers. So these are huge disease burdens that we have in areas in LMICs, but it's just the whole problem of inadequate facilities to even treat the few patients who we may actually diagnose. And in addition, there's low levels of medical education and cancer awareness. And for many patients, especially in the AYA group, we know that that may be the largest group of new infections. But this is the group of patients, the age groups that actually do not go for testing. And when they are tested, and if they may be positive for HIV, there's poor adherence to antiretroviral therapy. And in addition, we have very weak and incomplete both hospital and population-based tumor registries. So there's a multitude of problems that face low and middle income countries, and for those healthcare workers who want to treat children, adolescents, and young adults with cancer. So this is just some figures from my country in South Africa. The 815 reflects only the South Africans who were treated, but we have large numbers of patients from Africa that are not included. And as you can see here, there's a very, very, very small percentage of those that we are treating, say from the 15 and over. And the big problem is that in my country, my center is the only hospital that treats children and adolescents up to 20 years of age. And most of the other centers only go up to 14 or 13. Hence, you can see the numbers. And I've reached out to colleagues in Africa, and really also for Africa, the adolescent and the young adult, not so much the young adult, it's the adolescent is really the most neglected group in Africa, because not only for cancer, but for all adolescent diseases. And to me, this webinar comes at such an important time where some of us are really trying to address these issues and advocate for adolescent and young adults. So I've just looked at what was the publications that were available in Africa looking at AYA cancers. So this was a publication from my country from 2021. I was part of the study, and when we looked at in South Africa, of course, we know that in sub-Saharan Africa we have a major problem with the HIV pandemic, more especially in my country, South Africa. So this study was from 2014, looking at the age group 10 to 24 years and looking at those with HIV infection and cancer. So just to highlight what is said here in red, in those with a recorded HIV status, Kaposi sarcoma, non-Hodgkin's lymphoma, and Hodgkin's lymphoma, leukemia, and cervical cancer were the most frequent cancers in the AYAs living with HIV. A little bit different between the males and the females. In the females, it was KS, non-Hodgkin's lymphoma, cervical cancer, Hodgkin's lymphomas, and leukemias. And with males, they also saw the connective tissues cancers coming through. The problem with our lymphomas is that because we have the world pandemics of HIV and tuberculosis, many of our lymphomas are misdiagnosed as TB in people living with HIV. And this causes a delayed diagnosis and presentation with advanced disease. Also, we see a significantly lower odds of Hodgkin's lymphoma, especially as we know that even though it is not an AIDS-defining cancer, it is associated with HIV. And a lot of these patients who may have Hodgkin's may be misdiagnosed as tuberculosis. And with our lymphomas in sub-Saharan Africa, we know that our non-Hodgkin's lymphomas are associated with HIV, particularly those who may be diagnosed but not on treatment, may be ART naive, or those who have a poor adherence to the antiretroviral therapy. And also in those who may have poor compliance, so they have low rates of viral suppression. But we also know that we need to do a lot more research, because even in those patients who may be virally suppressed, we still have the non-Hodgkin's lymphomas in these patients. So I wanted to just go tell you briefly about another study that was done in my country. It was the South African Cancer HIV Match Study. And this was done for over a 10-year period from 2004 to 2014. And they looked at just over 780,000 young adolescents and young adults living with HIV. So of this group, 860 developed cancer, giving us an incidence rate of 61 per 100,000 person years. And here again, we see that it was the Kaposi sarcoma, non-Hodgkin's lymphoma, Hodgkin's lymphoma, cervical cancer, and the leukemias. In all of these groups, males had a higher rate. And also the important finding that came out of this study is that with the lower baseline CD4 cell counts, there were higher rates of KS, cervical cancer, non-Hodgkin's lymphoma, and Hodgkin's lymphoma, but that was not associated with the leukemias. So this was a publication from my country in 2021. So I was looking for other, because there's so little research that has been done in Africa on the AYA cancers. So I looked around and I found this, where they compared cancer registries between Zimbabwe, which is a city in Harare, my neighbor, and in Kiadondo in Uganda. This was a publication from 2021 from the German study group. And they were between the period 1991 and 2015, there were 1,881 cases of cancer recorded between these two cities. Well, 1,881 in Harare and 3,357 in the city in Uganda. And what the most important thing I wanted to highlight here is that the age-specific rate of all cancers was highest for the 15 to 19-year age group in Harare, with an incidence of 139.8 per 10 to the 6. So this was also concerning for me that in my neighboring country, that in this age group was the highest rate of cancers. But also they saw fluctuations in cancers related to other infections. And we know in sub-Saharan Africa, not only the HIV, but the KSHV and the Epstein-Barr virus are problematic and related to many cancers. Then I looked at the study from Nigeria, and I found this to be quite interesting because this may really be different from what we're seeing in Europe and North America, Australia, or Japan. So this was a study from 2009 to 2016, looking at 27 cancer registries in Nigeria. And among all the breast cancer patients, the proportion of AYAs aged between 15 to 39 with breast cancer was 30.58%, with a range of 20 to 42. But interestingly, when you look at the USA, in that age group, it's 5.6%, and in South Korea, 9%. Interestingly, in northern India, 33% of the breast cancers were in a similar age group. So I think that's really interesting and things that we need to look out for. But what was also interesting is that in addition, the highest breast cancer incidence was in women between 40 and 44. And we know that these may actually have been in the younger age group because a lot of these patients present with a delayed diagnosis. So for me, the most important things that we have to think about, and for us in sub-Saharan Africa, while we develop our programs, is that this cancer diagnosis comes at a time, a very crucial time in the lives of AYA. It is a time of developmental transition, their physical development, their personal relationships, the mental health, the quality of life, their education and vocational achievements, and also the shift to independence and autonomy. In addition, and very alarming, we know that survivors experience higher rates of adverse mental health outcomes, with a 30% higher rate of outpatient mental health visits and 20% increased risk of severe psychiatric episodes. And in LMICs, unlike maybe some of the other high-income countries, we live with the burden of shame and stigma and poor access to psychological care. Some may not even be poor, but actually non-existent. So I think for the future, we really have to, in sub-Saharan Africa, look at this age group. How do we advocate for them? How do we have early diagnosis and actually have easy and established referral pathways? How do we improve cancer surveillance? Because some of their cancers, which are not childhood cancers, may actually be amenable to screening. For example, the breast, the colon, and the cervix cancer. So, and a lot of us who are working in the childhood cancer space, when we think about screening, it's not something we do or we advocate for, because with our childhood cancers, it's not really about screening. And importantly for sub-Saharan Africa, to encourage testing. And if positive, how do we ensure treatment compliance? And about policy structures. I was looking at one publication about the restrictions on sunbed use in Australia and how that resulted in a precipitous decline in the malignant melanoma. So that may not really be for Africa, but there are other issues where we can have government policies to address AYA cancers. And also we know in many low and middle income countries, even though malnutrition is such a huge problem, the other aspect, the other side of malnutrition is the obesity, and these are real problems in sub-Saharan Africa. And we know that there are so many obesity-related cancers, so these are also important to address. And important that this population, we can increase their access to clinical trials and drugs. And importantly, like for example, I'm advocating that we are developing a new treatment area in my hospital that will cater specifically to the adolescent needs, to focus on their psychosocial care, their fertility preservation, but also to improve in healthcare systems in sub-Saharan Africa, capacity building, infrastructural developments, and importantly, retention of trained physicians. And I think that is my last slide.
Well, thank you so much, Dr. Naidu. That was excellent, of course. And then we will move very quickly to Ruzanna Papyan. She's a pediatric oncologist from Armenia, and she's going to present the AYA status in Asia.
Thank you very much, Gabby. I will share my screen now. Hope you see the presentation. Yeah, great. So I would like to present, well, first of all, thank you very much for this invitation. I would like to present the situation in Asia and mainly focus on Armenian perspective. So we already know about the term of Aya, and this is a no man's land. Just would like to add that the first Aya patient department was opened in UK in 1919, and now based on this model, there are already 27 dedicated units only in UK. So why unique? There are various and many papers about this, and one of my favorite one written by Dr. Andrea Ferrari, where here we can see all these signs of uniqueness and why it's called unique, starting from epidemiology with fertility, survivorship issue, end of life care, etc., etc. So what are the most common types in the whole world? Here we can see that the most common are breast cancer, thyroid cancer, and followed by other types of cancers. As I said, there are numerous wonderful papers, but these are mainly from developed countries, from Europe, from USA. And here we can see these papers that are focusing on the challenges, problems, and how to overcome that, just dedicated to adolescents and young adults. And according to another paper, here is written what is the age range, dedicated ISP in different countries. And here we can see that like only in the United Kingdom, there are 28 specialized wards. In some countries, like in Italy, it's in a way of a program and not a physical space. So what are the problems and how is the situation in Armenia? At this moment, there is no dedicated program. Of course, it was approved by the government, but still we are working on the details. So at this point, all patients until the age of 18 receive their treatment at our center, which is Pediatric Cancer Blood Disorder Center. And all patients above the age do receive their treatment by various adult oncologists in different hospitals. So this is our center, which was centralized, so cancer care is centralized in Armenia, and we are the only center that provide cancer care since 2019. We started our project with an analysis of how the situation is here at our hospital. We identified 130 patients, and mean age of diagnosis was 90 years old. What I would like to highlight is that, for instance, genetic consultations were done only for 5 patients. In many cases, the information was simply not available in the medical record. I would like also to say that all patients had psychosocial support, and regarding the fertility preservation, it was done only for male patients and for the majority of male patients in this age group. So median, another problem that we saw at our hospital is that a diagnosis delay, which was the median diagnosis delay was 55 days and the mean delay was 78. So here we can see that the majority of cancer cases are diagnosed with lymphoma, leukemia. Probably this can be explained by the fact that our center is also the only center that provide care to hematological disease. So all adult patients diagnosed with hematological malignancies were receiving their treatment at our center. So we already knew we have collected the data of all patients above the age of 18 diagnosed with lymphomas, leukemia. Starting our project and discussing this, we have decided to focus mainly on sarcoma cases, because we do have the sarcoma project at our center since it's a centralization since 2019, where we'll discuss all our sarcoma cases during the tumor boards. Up now, we have discussed 53 cases. For 34, the paraffin blocks were sent abroad to Germany because some tests were not available in Armenia. And so fortunately, everything was done for free for our patients. And for 30 cases, the final diagnosis was simply changed. So this is our collaboration between our center, and here we can see the University Hospital of Münster, which is in Germany. So we decided to have the sarcoma model as the model to start the AYA project in Armenia. So limitations that we do have in our country, of course, are similar to the limitation in any other country, in another developing country, which are delay of diagnosis, lack of awareness, of course, treatment abandonment rate, lack of multidisciplinary collaboration, and the fact that no patient was involved in clinical trials. So I would like also to present a paper that was published a couple of days ago. This was written by Dr. Shushan, who is mainly interested in IS and who had her 1-year fellowship in Italy under the supervision of Dr. Andrea Ferrari, who was world-known expert in IS. So this explains her interest in this. So we have published this paper, and we aim to understand how is this situation in resource-limiting setting. I mean, we have showed, and many of our speakers said about the situation in developed country in Europe, and we can see this huge amount of work was done in this countries, but how is the situation in developing countries? So I would like to say that there were really few articles available. I have extracted here only the information for Asian countries. You can see the wallpaper, which is already available in Frontiers. Regarding the Asian countries, we can see here that in Asian countries, IA patients represent a growing percentage of overall population. We can see that the majority were from Asian countries here in compared to other countries. I mean, the IS with cancer. There were really very few articles published from Asian countries. There were 2 papers from Bangladesh and Jordan, which showed that the IA age group compromises about 44% of the total population. Another thing was there was a wonderful paper from India, which mainly was a descriptive analysis and showed the data from 28 population-based registries, and they showed that the majority of the patients in this age group were diagnosed with head and neck cancer, bone and CNS tumors, and another paper from Jordan showed that the survival is 72%. But of course, these are from the single country experience, single institution experience. So we do not have the whole picture of the situation in Asia, unfortunately, at this point. Another paper that I would like to just say a couple of words about this paper was a study launched by ESMO, SIAP, and SIAP Asia survey. They have sent the survey to 22 Asian countries, to all doctors who have somewhat connected with the patient in this age group. There were 268 responders, and the majority were from South and Southeast Asia. So what I would like to say here, that the majority here we can see reported that their patient had access to and support of professional psychologists. So these are from positive things about the situation in Asia. They had access to social workers, psychotherapists, occupational therapists. They had access to nutritionists or dietitian. So, but when we see the limitations are similar. I mean, which are significant insufficiency in access to a quality of specialized dia-focused cancer care, absence of adequate infrastructure, of course, the absence of the training, lack of the training programs for doctors and educational programs. Treatment non-compliance, still there is a high, there is a high abandonment rate, especially when we look on the rural areas. From me, I would like to add also about the situation in Asia is that there are really limited number of studies, papers, and projects launched specifically in Asian countries, which is a huge problem nowadays. If we look just to compare the number of papers provided from European countries and from Asian countries, the difference is huge. So more collaborative efforts are needed between developed and developing countries, especially if we will have this platform, this opportunity. That would be great, because there is this would be like a first step towards the improvement of the care of adolescent young adults in the developing world, especially in Asia. So this is the end of my presentation, my last slide, and please feel free to ask me some questions. Thank you.
Thank you so much, Ruzanna. This was great. And for the sake of time, I'm going to start sharing the Latin American experience. It's already 10 a.m. here, so I will try to do it as quickly as possible. I want to be mindful of everyone's time. So Latin America, so it's a very diverse region. There are 21 countries. We have mainly 2 languages that we use, some indigenous languages, huge, big populations, countries that they have more than 400 million people like Brazil, and smaller countries that may have very populations like in the thousands, but we all share similar problems and difficulties. So in this presentation, I'm mainly going to talk about 3 countries, Chile, Argentina, and Brazil, because those are the ones that I was able to gather some more specific information about AYA care. That is not fair for the whole region, as there are a lot of other initiatives in other countries that I'm not going to talk about at this point. So I'm going to start very briefly about Argentina. In Argentina, if you see the population age from 15 to 35 years old is about 14 million people. And these are the data from our national registry. And among this population, when we look at the data from those age 15 to 19 years of age, we can see that the cancer distribution among them is basically mainly related to patients with leukemia, lymphomas, solid tumors, carcinomas, and CNS tumors. The main thing I would like to mention here is that in my country, where I live in Argentina, registry for patients with cancer basically only includes pediatric patients up to the age of 15, now extended to 19 years old. But there is a big gap of data about adult cancer that we don't really know the exact incidence. So I will mainly talk about 2 big hospitals in my country. One is Hospital de Clínicas José de San Martín, that's where I work, and the other one is Hospital Nacional Profesor Alejandro Posadas. Those are the 2 main hospitals that are leading some initiatives in AYA care. So about Hospital de Clínicas, this is a big university hospital that is part of the University of Buenos Aires. It has a pediatric department, and it also has an hematology department that has more than 50 years with all the subspecialties. And in the last few years, it was created an AYA group that we care for patients up to the age of 25. So this is since 2002. And the model that we use is this, like in a main hospital, which we call in Spanish, institución polivalente, which means basically it's like a big hospital that includes pediatrics and adult patients. There is within that an AYA program. So the way it works is that we share patients and the workload with adult hematology and oncology, and the pediatric patients can be admitted up to the age of 18, and adult patients after the age of 15 in the adult ward. There are outpatient services for chemotherapy and transfusions. There's a survivorship clinic, some fertility services, and genetic counseling. Psych-oncologists that they're specialized in AYA care and specialized nursing. So we're very lucky in that sense that we have a big range of specialties that are helping us, though we have a lot of challenges, and I will tell you a little bit. And these are the main ones that we were able, that Mariana and Anna, who helped me with this, were able to gather. One of the main ones that we have is the late diagnosis. Most adolescents and young adults, they get to being diagnosed late within their disease, and that is because of different reasons. One of them is that they don't have a place to go. So if you're a pediatric patient, so less than 15, all the care for oncologic patients is centralized in pediatric hospitals. So it's a very clear destiny or the destination for patients to go. So everyone knows that they have to be referred to those hospitals. When you're past that age, there is a big gap, there's a big question. No one really knows where to go. And most of the time we see patients self-referred to our services. They just show up asking for an appointment. There are problems with health insurance. and difficulties to get imaging studies if they don't have any health insurance. The doses of chemotherapy sometimes are challenging. As they were saying previously, there's problems with malnutrition, but we also see a lot of problems with obesity. Our patients are big, and how much chemotherapy to use, how much is safe, and we see a lot of side effects that we are not so used to seeing pediatric patients, so it might be related to that. The maximum age for AYA patients, that is the big debate, and it's not just like a philosophical debate, it's based on who is going to treat it and which part of the hospital or different hospitals will be able to treat those patients. We don't have an inpatient ward for AYA patients. Fertility preservation, though we have access, is challenging, and most of the time patients have to pay for that. There's problems with economic problems and job insecurity, and adherence to treatment sometimes is challenging as well. The other hospital is Hospital Posadas. This is a huge hospital, one of the biggest hospitals in Argentina. This hospital is located in the metropolitan area of the city of Buenos Aires. It has a really big adult oncology department. They have more than 11,000 consults per year and approximately 1,000 new diagnoses per year. So the amount of patients that they see is way bigger than the pediatric department, where it's a smaller department within this really big hospital. And in this Hospital Posadas, we're really happy to say that this will be the first AYA department unit in our country. They got a grant from our National Cancer Institute, and they are working right now in creating this AYA unit. So this will be a great first example, and we hope it's not the first and only, just the first one of many that we can just start building up in Argentina. They have very good therapeutic support group and discussion groups, a fertility team that is very well established, and they were able to manage working together between pediatrics and adults in a more fluid way. Another good set of news in Argentina is that we, in the country, we were able to pass a law that is the creation of a comprehensive protection regimen for boys, girls, and adolescents with cancer. So this basically means that by law, all children up to the age of 19, so all Argentinian residents, they will have access to some financial aid and special working license and housing and free public transportation, so they can, during this painful process of being diagnosed and treated with cancer, they can have some financial help that will help them go through this time. Then moving to Chile, which is a country that is next to Argentina, going west. So in Chile, cancer is the leading cause of death. And during the pandemic, they saw a big delay in diagnosis and treatment, especially in the adults. What they noticed there is kind of the same that we see in Argentina, that for every child under 15 with cancer, there are 100 adults with cancer. So adult services, they're usually overloaded with patients, where pediatric units, we still have a lot of patients, we struggle with them, but it's still the number is way smaller. And the 5-year overall survival in patients with cancer, we see that this overall survival, they reach up to 70% in what is this AYA, but as people age, that survival goes down. So how oncology is organized in Chile, so most of the population go to the public health system. There are 2 programs, one that is called PINDA, that is for patients 0 to 15, or patients that they're younger than 25 and relapsed with a second cancer or had a second cancer. And then PANDA, that those are for patients older than 15 years of age. So the medical care is covered by law for all those patients diagnosed with cancer with 15 years of age or less than that. But if you're older than that, then you have to pay for your care, which is a problem. Some of the changes that they were able to include the AYA population in Chile is that they included an ALL protocol in 2007, the group PANDA, the adult group, and they included patients from the age to 15 to 30 years of age following a COG protocol. And they could see that the survival in this group was way higher in patients treated with a pediatric protocol than with an adult protocol. This is no news. Everyone knows, at least in ALL, that pediatric protocols work better for AYA patients, but this is like proven in a different setting. So in Chile, they proved that it also worked for them. The way that they've been trying to work to break that gap between pediatrics and adults is by twinning between hospitals. So the concept of twinning is more common, like between a high-income country and a low-income country, but here they did it between adult hospitals and pediatric hospitals as a way to create a bridge and a place where patients over the age of 15 can be treated. So this twinning hospital is between adult hospitals in the city of Santiago and pediatric hospitals, where they share the care and they share like the decision-making of patients within that age group. And then an interesting story that I don't know if it happens, also in your hospital, that during the pandemic, there was an over-occupancy of beds in the hospital, and a lot of pediatricians and other specialists have to care for adults. So all the adult cancer patients, they had to go to the pediatric unit, and pediatric oncologists have to learn how kind of like to care of adult cancer patients. And that brought experience of working together and speed up the process for some hospitals. So even though that opened like a new gates and a new vision of opportunity of how to work together between pediatric and adult oncologists, there are some problems with that they still see, like historically pediatric patients in Chile, they are up to the age of 15. There's no infrastructure for AYA patient. If the patient gets really sick, does it go to an adult ICU or a pediatric ICU? And if the patient has to go to the emergency department, if they go to a pediatric one, they will see up to the age of 15. So it's not only the oncology team that has to be on board, it's the whole medical system that has to adjust to this new, we can say, new population. And then last thing, in Chile, they should have a national child adolescent cancer plan as of June 2022. They want to design measures and implementations proposal for compliance with the national cancer law, and they have representatives of different teams. And the goal is to increase the age of care up to the age of 20. So move it from 15 to 20 years of age. And then moving to Brazil. Brazil is a really big country with more than 400 million people. The INCA, which is the registry in 2016, they evaluated that from the age group from 15 to 29 years at 24 institutions, the median age percentage of neoplasm was 4.3 in Brazil. And that included, basically means that there were 213 new cases per million people, and with a survival rate of 65%. So the mortality by age in Brazil, patients age 15 to 19 is 61 per million, 20 to 24 is 54 per million, and 25 to 29 is 88 per million. So there is like still significant mortality in the AYA. So even though with all that, there's been a lot of research and publication and enthusiasm about AYA in Brazil. This is a paper about the incidence of cancer. They noticed that in these age groups 0 to 19, there were around 8,000 new cases. And they also did this study that is called Challenging Outlook of Caring for Adolescents and Young Adults with Cancer in Brazil. This is a nationwide survey where they surveyed 250 doctors for all these different societies in Brazil, and they evaluate the standard of care AYA patients across the country. 90% do not have an AYA specialized department, and the difference is in between different regions in Brazil, especially regarding referral to specialists, was significant. The Southeast part, 34.6% refer to fertility clinic, for example, and the North part, 100% did not refer. And there was, of course, difficulty starting clinical studies, like 40% included patients routinely, but 23 occasionally, and 36% they never did. So just a little bit about Hospital de Clínicas in Sao Paulo. This is the hospital where Dr. Maristela Bergamo works. This is a big hospital where they treat around 1,800 patients with cancer in 2021. Among those, 10% were AYA. They have 3 specialties that include pediatric, adults, and oncology, and adult hematology. And they have different services like late effects clinic, cardiotoxicity, fertility preservation, and genetics. And they work with the referral and discussion of patients between different specialties whenever that is necessary. They started a very good project there, which is a retrospective study to try to register all patients AYA, and that just reporting this type of data like sex, age, tumor type, vital status from 2018 to 2022, just to understand and know what is the actual number of patients, AYA patients treated, how they are treated, and what diseases they have. At least they lack this data. And also from Brazil, they are now including AYA in a lot of all their different congresses. And this is the program of the Suburbia Slough program of last year, that they have a whole session for AYA. And they also include that in most adult congresses, that the AYA is starting to be more like an active topic. So what else are we doing in Latin America? Because it's not just about different countries, we're also trying to work together. So from Slough, that is the Latin American branch from SIAP, we created a Slough AYA chapter. We started doing a survey where we have more than 250 people who participated in that, like basically signaling that the interest in AYA is big in our region. And we're now working in an AYA patient registry to provide a platform where they can register their patient, and a survey about AYA resources and challenges in our region. And thank you everyone for that. Your time. And I know it's already 10:20, it's really late. So I'd like to thank all the speakers for staying here. 20 minutes past the time. I don't know if there's anyone from the audience who has a question. I would like to say that it was really nice to have you all here. That this is just the first one of many webinars, and that we are hoping that we can create a specific webinar for each region. One of the questions I have for the speakers that they're still on is, how do you think will be, or what is the best way to reach pediatrics and adults within either your country, your hospital, or the region where you live? Because that sometimes is a big challenge. The age at diagnosis is like an external determinant that affects the patient either going to one hospital or another, but that doesn't mean it's the best place or the place where they can provide the best care. So what would you think it would be the best advice, or how you handle that? Ruzanna, I saw your camera, so.
Well, yeah, exactly. I was about to comment, when we talk about like adolescent young adult, of course, it's very important. I mean, to have the collaboration with GPs and other people, but of course, it's very important to have a very close relationship with collaboration with adult oncologists. It's not always easy thing to do, but it's mandatory, because they are ones who are, for instance, at our hospital, I see already the tendency, especially when we talk about sarcoma cases. They always love to us to be involved in the treatment, and they are asking questions. I mean, adult oncologists where the young adults are treated above the age of 18 with diagnosed with sarcoma. So in my opinion, we should have like a very close collaboration with adult oncologists as well. I mean, starting from that point. Basically, in my country, it would be one of the key points, because one of the problem is there. Lack of collaboration. So this would be, for us, for my country, it would be like the first step to overcome these problems.
Mm-hmm. Apostolos, what do you think? How are things in Greece?
Yes, in Greece, I think that the main is to collaborate between adults and pediatric oncologists. I think that about 20% of cancer in adults, adolescent and young adults, are of adult origin. Okay, and so the adults must be treat them, and the others, if we cannot accept now in pediatric hospitals, but they have to treat. We have to treat them with pediatric inspired trials. So I think that every adolescent young adults must be treated in a clinical trial. So in Greece we have many now to use. We participate in many Sea of Europe trials. And the other is to push the politicians in Europe to give a new age definition and to give place for these young people to be treated.
Yeah, I guess we should all call our politicians
Yes,
to help us with that as well. And I think one of your points is really important, that most of type of cancers are adult type of cancer, like what Dr. Naidu was saying, breast cancer is now more common, like at a younger age. And we see that, and I'm a pediatric oncologist, I don't know how to treat breast cancer.
yes.
So like working together is the way to go. So thank you everyone for your time. We hope to continue to working with all of you together. If you're interested in AYA, please. Oh, Dr. Naidu, I don't know if you would like to say anything.
No, Gabriela, I just wanted to add is that I think for many places in the world where AYA cancers are sort of as one of the speakers said, the no man's land. What we are trying to do in our country, or I'm trying to do, is to include it as part of the National Children's Cancer Care Plan. That it's children, adolescents, and young adults. So for me, I think if we can get our Department of Health and higher up in the National Department of Health to really that we can write this plan, it may go a long way to including pediatricians to look after at least those who are until 20 or a little bit older, and then we can work closely with our adult oncologists, because often we're in the same hospitals, that we can share the care for the young adults.
Yeah, that's an excellent point. Well, thank you everyone for being with us today. If you're interested in AYA care, you can join the Global Health AYA Network. We are trying to make this a space where everyone can share and network and like possibly create projects that we can all participate. So have a great beginning of the week.
Thank you so much.
Bye-bye.
Bye-bye.
Bye.